Hello, everyone, and thank you for joining us for Arthritis Talks, Understanding Rheumatoid Arthritis. I'm Dr. Sean Bevan, Chief Science Officer at Arthritis Society Canada. We've come together for this event from many different places, but I would like to take a moment to acknowledge the land on which I am located on and on which our Toronto office stands, which is the traditional territories of the Mississauga of the Credit First Nation, Anishinaabe, Huron-Wendat, and Haudenosaunee Indigenous peoples. Today, this meeting place is home to many First Nations, Inuit, and Métis people, and I am very grateful to have the opportunity to live with my family and work on this land. Now, rheumatoid arthritis is a common autoimmune disease that causes inflammation and pain in multiple joints of the body. In fact, more than 250,000 people living in Canada have it. And tonight, we are so fortunate to be joined by Dr. Stephanie Garner, a rheumatologist based out of Alberta, who will share her insights into the complex world of rheumatoid arthritis. So before we get started, just a few logistics. First, this webinar is best viewed on a laptop or desktop computer. If you have any technical difficulties, please email arthritistalks@arthritis.ca for assistance. If you have a question for our presenter, you can submit it through the Q&A button at the bottom middle of the screen. And as always, we will try to get to as many questions as possible during the hour that we have together. You can click on the chat icon in the bottom middle of the screen as well to access the chat and connect with other participants, as well as our chat moderator. If you find that distracting and you'd like to close out of the chat completely, just click the red X icon. We are pleased to continue to provide captioning of our webinars to accommodate the diverse needs of our audience, so you'll see that running along the bottom of the page as well. So many questions we received in advance follow similar themes, so we'll get to those first before going into a live Q&A at the end of the session. And before we get started, I want to thank our event partners, Pfizer, United Way Winnipeg, and others for their financial support of our Arthritis Talk series. So with all of that, let's please get started. And first, a warm welcome to today's expert, Dr. Stephanie Garner. Dr. Garner, can we just start with the basics? Start us off by chatting more about what exactly is rheumatoid arthritis.
Hi, thanks for having me. So, rheumatoid arthritis is an autoimmune disease. And an autoimmune disease means that your body stop recognizing itself as who, normal day to day and starts thinking it's foreign and it starts attacking it similar to how it's going to attack bacteria or viruses or cancer cells. There are lots of different types of autoimmune disease. And in rheumatoid arthritis, the type of autoimmune disease, this type affects the lining of the joints. So it's going to cause inflammation and swelling of the joints. Rheumatoid is one of the more common autoimmune diseases. It affects, as Sean said earlier, about 1% of the Canadian population. Usually it comes on when people are in their middle age. We definitely see it in more women than men. It's about 70% of females, 30% males. And it classically causes a symmetric arthritis in the hands. So it's going to affect the small joints of your hands. It's going to affect the right side and the left side. It can also affect your knees or your feet, but it's most commonly occurs in the hands. Elbows can be another site, and it's usually the right and the left get affected. It is a chronic disease, so that means that generally when you're diagnosed with rheumatoid arthritis, I usually tell patients that we're going to be friends for the next couple of years at least. Most of the time we can get people treated and get them in low disease activity or remission, so we don't have to touch bases frequently. But for that first little bit, when you're first meeting your rheumatologist, you're going to get to see each other on a regular basis to try and get everything under control. One of my jobs as a rheumatologist is to make sure that the rheumatoid arthritis isn't affecting other parts of your body. So it can definitely affect your lungs. It can affect your brain sometimes or your nervous system. And then untreated rheumatoid arthritis is actually really bad for your heart and for your blood pressure. So we really want to be on top of rheumatoid arthritis to make sure it's not affecting other joints and then other organs. And if it is, we get on top of it. So what are the symptoms? So when I'm seeing a patient, a lot of people have joint pain, and there's a lot of different reasons for joint pain. It's kind of like a headache, right? A lot of people get headaches, and there's a lot of reasons for having a headache. But in rheumatoid arthritis, the key differentiating feature between wear and tear arthritis, like osteoarthritis, and an autoimmune disease is going to be that joint swelling. So the swelling is from the inflammation of the lining of the joint. It's going to cause redness overlying the joint. It'll cause stiffness. So a lot of people say to me, I'm having a really hard time making a fist, standing up, getting out of bed. And they may or may not also have other symptoms too, because if your body is not working on its sort of normal day-to-day functions, and instead it's fighting itself, it'll cause fatigue, fever, and weight loss. And that fatigue can be really difficult for our patients. You can be sleeping poorly. You can get something called fibromyalgia, which is where you get more of a diffuse joint pain because you're sleeping so poorly. So we're really watching out for these symptoms when we're seeing patients in consultation. So at that first visit, and then this is the stuff we're asking about over time to assess whether or not the disease is controlled. And the pictures I've got there, you can see that the woman in the picture has swelling over her knuckles. And that's one of the key things I'm looking for when I'm seeing a patient, looking at the symptoms and signs for rheumatoid arthritis. Now, what causes rheumatoid arthritis? We don't really have a great handle on what causes it. There's definitely some theories, and they're starting to get more and more knowledge about this every day. Most autoimmune diseases, there's thought that there's an underlying genetic predisposition. So usually it runs in families. So if your aunt had it, you might be more likely to have it. There's also some risk factors we know or increase your risk of developing it, like smoking, or if you've got poor dentition. So if you're getting a lot of cavities or you're not going to the dentist on a regular basis. Infections. So we definitely saw some increase in some of the autoimmune diseases post-COVID or other infections. And then there's a thought that hormonal changes can also contribute. Because as I said, we see this more in women than men. And we do see an increased onset of rheumatoid arthritis in women after they've had babies or during the perimenopausal period. We don't really understand why we're seeing those changes or what, we don't have ways of treating that yet, but we're definitely starting to see patterns. And there's a lot of interest, as I said, in looking at how we address this. And one of the theories on how we develop rheumatoid arthritis is that if you've got this genetic abnormality, then your threshold to develop rheumatoid arthritis is a bit higher than someone, or is a bit lower than someone else's. So I don't have genetics for rheumatoid arthritis. So I could be a smoker. I could have poor oral hygiene. I could get an infection, and I'm never going to get high enough where I'm going to develop, sort of push over and develop rheumatoid arthritis. Versus if someone has a genetic susceptibility, they're sort of already a bit increased, and then they get an infection or they start smoking, or they go through childbirth, and they get sort of pushed over and develop rheumatoid arthritis. So these are some things I ask about when I'm seeing patients, but in a lot of cases, none of these risk factors are present, and people will still develop rheumatoid arthritis. So
So
making, oh,
if
sorry.
someone, no, that's okay. I'm just going to give you a pause.
Yeah.
If someone does suspect that they have rheumatoid arthritis or another type of inflammatory arthritis, how would they go about getting diagnosed?
Yeah, so the first stop is always your primary care physician, because in our current Canadian healthcare system, they're going to be the gatekeeper. So you're going to want to see a primary care physician, so your family doc, or depending on where you're living, that might be a nurse practitioner. Unfortunately, the access to primary care across Canada is quite poor, so that might be a walk-in clinic. But what you want to do is you want to go in and first see that person. And I ask my patients to be really upfront about what they're worried about. So if you're worried you have rheumatoid arthritis or another type of inflammatory arthritis, so autoimmune disease, then you should tell that person and say, hey, this is what I'm worried about. This is why I'm here today. And then they're going to ask you questions about, are your joints swollen? Are they stiff? Do you have morning stiffness when you wake up in the morning? And then they'll send a referral to your rheumatologist. And in Canada, we try and triage referrals for new rheumatoid arthritis as being seen within about a month. I will say that often is not what's happening in practice. There's a huge demand for care across Canada. Depending where you're living, wait times are definitely going to change. But ask your physician. Is there a phone number you can call? In a lot of the large cities, they can call and speak to a rheumatologist, at least to get some idea of what investigations should get going before the referral's made. Or is there a way to sort of get some treatment started before you see rheumatology? But I will say a lot of this is going to be advocating for yourself, and feeling comfortable doing that because you know yourself best. All right.
Okay, wonderful. And I think, Stephanie, you probably need to advance your slides for the next question. That's okay. Did you want to go through any of this, or are you okay?
Yeah. So there's a lot of different types of arthritis, as I said, and it's kind of like headache. There's a lot of reasons to have a headache. So when I'm seeing patients, the first thing I want to know is, do they have itis or not? So we talk about osteoarthritis, we talk about rheumatoid arthritis, but itis actually means, we put it at the end of the arthritis, it means joint inflammation. So when I'm seeing patients, do they actually have inflammation of the joints or not? Or do they have wear and tear arthritis? Because we know osteoarthritis is incredibly common across Canada. It's way more common than rheumatoid arthritis. And osteoarthritis is from wear and tear, and our treatments are very different. So that is often the sole sort of my main focus when I'm first meeting someone. Is it inflammatory? So is there swelling, inflammation, or is there not? And then some of the other questions we ask are, is there any antibodies? So we talk about seropositive. And does that mean, are there any antibodies that we know are attacking the lining of the joints? Or they're found in the blood when we do blood work? So rheumatoid arthritis is usually a seropositive arthritis, which means that your rheumatoid factor, which is a blood test for rheumatoid arthritis, or an anti-CCP, which is a blood test for rheumatoid arthritis, is positive. So we're always looking for that when we're checking and talking with patients and having a look at their blood work. But there are definitely other types of inflammatory arthritis, and psoriatic arthritis is another type of inflammatory arthritis. So you might, and often it takes us a bit of time to figure out which direction we're going when we're seeing people. So I always explain, this isn't like a heart attack where, you go in, you go into Emerge, you tell them you're having chest pain, your blood test positive, off you go to the cath lab, there's the blockage, they put in the stent and you're done. A lot of this is a little bit more detective work and looking at over time. So one of the key things you should be prepared to sort of think about, and it's really helpful if you've come in to your first appointment or even your follow-up appointments, right? Because we see a lot of osteoarthritis in the population. And as you get older, we see more wear and tear osteoarthritis. And then we have a little bit of trouble sussing out sometimes at follow-up. Is it your osteoarthritis wear and tear or damage that's a problem, or do you have active inflammation? So when I'm trying to make this sort of check the difference between the two, I'm looking at the pattern of joints involved. So as I said, the small joints of the hands, we see that classically in rheumatoid arthritis. Are you stiff when you get up in the morning? Now I know everyone might, those first couple of steps, your feet kind of might hurt a little bit. You got to get going. But what we're looking for is morning stiffness lasting more than half an hour. Are your joints better with activity and worse with rest? Because osteoarthritis, usually if you sit down and you give your knees a break, they're going to feel a bit better. But in rheumatoid, it's actually usually that you get going, and as the fluid in your knees sort of loosens up and warms up, the knees are less painful and other joints are less painful. And then do you have any systemic symptoms? So symptoms in other places in your body like fever or weight loss. And this is a great tool, this picture here, that the College of Family Physicians did with the Arthritis Alliance of Canada, trying to help family physicians tell the difference between osteoarthritis versus rheumatoid arthritis, because it is tricky. When you do see your physician, either your primary care physician, or when you do come to meet us as rheumatologists, I'm very good at ordering testing. Nobody sort of comes in through to see me who doesn't get blood work in most cases. So normally what we're doing is we're looking at your blood counts. So we're looking at your red blood cells, your white blood cells, your platelets. We're looking for markers of inflammation. So a C-reactive protein is a marker for inflammation. When it's elevated, it usually tells me, okay, something's going on. I need to figure this out. We look at how well your kidneys work because a lot of our medications go through your kidneys, your liver, because a lot of our medications can irritate the liver. And then we do blood tests for rheumatoid arthritis. We do the rheumatoid factor and anti-CCP. And then almost always I'm going to get x-rays. And I usually get x-rays of whatever's sore, and then always the feet, because sometimes people have damage in their feet before they have symptoms in their feet. Ultrasound is another modality, and it's really, really uncommon now to start off with an MRI or CT. But we do use those if what we're seeing or what your symptoms aren't fitting clinically. Now, I always tell patients, and I tell our trainees this because we have a lot of residents rotating through. In rheumatology, we have to look at the whole picture. So I always liken this to a pregnancy test. So if you take a pregnancy test and it's positive, you're pregnant. There is not a lot of uncertainty there. That is a pretty good test. But a rheumatoid factor anti-CCP, that is the complete opposite. So in the right clinical setting, so if you've got joint pain and swelling and your rheumatoid factor is positive or your anti-CCP is positive, that's really helpful. And then I would make a diagnosis. But a lot of people get blood work and for other reasons. And if those tests are positive, but you don't have any clinical symptoms of rheumatoid arthritis, then you probably don't actually have rheumatoid arthritis. So it's not like a pregnancy test or testing. We have to take the history, so that history of stiffness and swelling. We take the blood work that we've done, we take what we find on physical exam and imaging, and we pull that all together to make the diagnosis. The other thing we look at a lot, and this is where a lot of frustration comes in, patients have waited months to come in to see us, and you want a diagnosis. I want to know what's wrong. But often it's over time that we need to figure things out. So a little bit of patience sometimes can go a long way, and just an understanding that rheumatoid arthritis and rheumatology generally evolves over time. And it's often time which allows us to predict what's going to happen over time.
Okay, thank you, Dr. Garner. We've also had questions come in related to quality of life and life expectancy for a person living with rheumatoid arthritis. Could you elaborate a little bit on those things?
Yeah, definitely. So we've had huge changes to our treatment of rheumatoid arthritis since sort of the late 1990s to now. And really in the 90s, we had medications like methotrexate, leflunomide. But in the late 1990s, early 2000s, the biologics were discovered. So the most common one, people will think about, you'll see ads on in the TV for Humira, which is adalimumab, or Enbrel. They were the first biologics, and infliximab. And over the past 20 years or so, we've gotten many more medications. So it used to be we would try what we could do with what we had, and we didn't really have a ton of options. So patients tended to have really, poorly controlled disease. And we know that it's poorly controlled disease that will decrease your lifespan. So this is some great work that's been done by Diane Lacaille, looking at some of the administrative data in Canada. And it's shown that over time, life expectancy, while decreased compared to the healthy population, is actually improving. And that's probably, it would be reflecting the advances in treatment that we've had. So the key thing there is that we need to be on top of your disease treatment so that we can make sure that you have the best life expectancy. Quality of life is the other big concern, and we definitely do see patients with rheumatoid arthritis have a poor quality of life than healthy controls. And the reason for that is that, you have a chronic illness, you're going to be tired. As I said, your body's fighting itself. Our medications do have side effects. You need to be aware of that. You're going to get joint pain, stiffness, disability. So we do see challenges in terms of quality of life. that being said, is we're addressing this, and we're addressing this nationally as well as locally. So there were, aggressively looking at access to medication. So in terms of the biologics, making sure they're available provincially. I know the Arthritis Society's really helped with that, looking at making sure we're training more rheumatologists so that patients can get in to be seen quickly. And then making sure that we have mechanisms in place to support patients. So we know that if you've got access to education around your disease, physiotherapy, if you've got great support networks, if you're getting this kind of education like the talk tonight, this all sort of will help to contribute to a better quality of life. And then having a stable employment, access to, food, housing, that's all going to contribute. And there's been a lot of work nationally on this to try and address this.
Okay, thank you, Stephanie. So this next question is important. We received lots of questions about medications. So how is rheumatoid arthritis treated?
So our overarching goals for the treatment are, as I've said this before, it's that early access to care, because we know that early aggressive therapy is better in terms of long-term outcomes as well as getting disease under control. So really, when I take the phone calls from Emerge or from family physicians when I'm on call, I always agree to see patients. We're always trying to get them in when we're doing our triage protocols, looking to get these patients with inflammatory arthritis seen quickly so that we can get them started on medication quickly. So that's sort of one of our first goals. The other big goal is that we need to make sure that all our treatment decisions are being made together, right? I hand out prescribe a lot of medication. The medication requires monitoring. You need to be really comfortable with the risks, because if you're not comfortable with the risks and understand how the medication works, there's a lot of literature to say people won't take the medication. So we got to make sure that we're having that shared decision making. And then our goals and with the medications is going to be low remission or low disease activity. So that means no joint pain or swelling, or very, very minimal joint pain or swelling. And we want to do that because we want to control the symptoms. So you want to feel better, right? So you want to get rid of that pain. We want to get rid of that inflammation, that stiffness. And then we want to prevent damage. So untreated inflammatory arthritis can destroy the joints, and we can't fix that one that's happened. And when you destroy your joints, you've got damage to your joints, that's going to cause disability. And that all leads to improving quality of life. So these are sort of our overarching goals, and we're trying to treat patients with rheumatoid arthritis. When we're looking at specifically how we're going to do this, so the core treatment is going to be disease modifying medications, and I'll talk about those in a second. And what those drugs do is they change the course of the disease. We want to treat pain, right? So people have symptom control. There's a lot of lifestyle factors, and these are things you can do usually in support with your family physician or with physiotherapy, trying to get on top of lifestyle. Attending talks like these, we have nursing support in the clinic I work in, getting that education and support. There's some preventative health we can do, and then physiotherapy, which can be a little bit tricky depending where you are in terms of access, because it's often not publicly funded. And then at the core of that is having a multidisciplinary team. And that might look different wherever you are in Canada. So here in Calgary, for me, that's having myself, we've got some clinical nurse experts in rheumatology, your family physician, and all of us working together to make sure you have the best outcome. When we talk about acute symptom or pain relief, steroids come up a lot. And I find patients either love steroids or hate steroids. And when I'm on call in the hospital for rheumatology, I jokingly say I'm the steroid fairy, because that's often my role is, do people need steroids, yes or no? And in rheumatoid arthritis, giving someone some prednisone or an intramuscular injection of Kenalog or a joint injection, that helps right away. Most patients will have relief of their symptoms within a day or two. The problem with steroids is that they work really well, but they have a lot of side effects. And most people who've been on steroids do not want to go back on steroids. So steroids can cause weight gain, they can cause thin bones, osteoporosis, thin skin, easy bruising, high blood pressure, diabetes. The list is like this long. There's a picture here where you can see all the harms of steroids, but they work and they work quickly. So often we'll use steroids to treat that pain and inflammation to give our other drugs time to work. Depending on if it's safe for you or not, we use NSAIDs, so that's going to be Advil, which is ibuprofen, Aleve, naproxen. Those are generally out of the over the counter, and we do have some prescription versions. Tylenol works great. I usually suggest using Tylenol arthritis. It can be acetaminophen for arthritis. It's got a longer half-life than regular Tylenol, so you don't have to take it as frequently during the day. And then heat or cold are really beneficial. Some people find CBD, acupuncture, TENS, those can all be helpful too. But it's really what works best for you in terms of acute pain or symptom relief. The disease modifying anti-rheumatic drugs, so the term for that are DMARDs, are really going to be there where we treat the disease though. And while steroids work really well, as I said, they cause a lot of harm. So what we're doing is we're using these disease modifying drugs to actually treat the disease. So I often tell patients your immune system, I do tend to talk with my hands and it's a little bit hard to do here, but your immune system is working sort of up here and we need to bring it down here. And we do that with the disease modifying drugs. And they're treating that underlying inflammation. There's a lot of different types. So we have almost 20 probably different types of disease modifying drugs. We break them down now. And, I've been in practice since 2020 and the language has changed for me since then. So things are always changing, but we talk about the conventional disease modifying drugs. And these are the drugs most people are going to be on and what we use first. They work well and they're inexpensive and they're generally very well tolerated. And those are going to be drugs like hydroxychloroquine, methotrexate, sulfasalazine, or leflunomide. And if you have a new diagnosis of rheumatoid arthritis, you're definitely going to be familiar with these medications. Most of provincial payers, which would be like Trillium or Alberta Blue Cross, and the private drug companies are all going to say you have to try these up front. And then if these don't work, then we move to something called the biologics or the targeted synthetic DMARDs. And these are sort of advanced therapies. These medications are usually an injection. We do have some that are pill options. They're quite expensive. So the regular DMARDs that we've had forever, they're a couple of $100 a year, probably, around $500 for the more expensive one, versus the biologics are about $14,000 and up a year. So that's why most of the insurance companies say we have to try the cheaper stuff first. And you might also notice that you're not just getting one drug, but you're getting a couple of drugs. And that's because we know these medications work really well together in combination. So they work synergistically. So very often we'll combine one or two or three drugs together to see if we can get that control. And we do that early and we do that quickly because we really want to get people in control and symptom free as quickly as we can. One of the things I spend a lot of time talking to people about is the safety of these medications, but we're always balancing the safety against the benefits. And these drugs are well proven to prevent damage. They improve quality of life because they treat pain and inflammation. And they actually decrease the risk of cardiovascular disease and other complications. So there's a lot of argument for treating patients. There are risks with anything. So even if you're taking Tylenol, there's risks associated with Tylenol. But these medications in particular, the biggest risk is going to be infection, and that's what we worry about. So when we're seeing patients, we're always taking the entire picture into account. So someone who's 25 years old, I'm a lot less worried about infection than someone who's in their 70s who might have diabetes or high blood pressure. Now, the risk of infection is far outweighed by the benefits of treating the disease. These medications commonly cause stomach upset, Not everybody gets stomach upset, but we do see it quite a bit. But we have ways of treating the stomach upset, and we have lots of medication. So if you're not tolerating something, we just need to know, and we can look at other options. As I said, we used to have, 4 or 5 drugs for rheumatoid arthritis, and now we have almost 20. So we've got lots of choices. The other thing that commonly comes up is liver irritation. So usually for the first month when we start these medications, we do blood work once a month because we're looking to see if it irritates um, the liver or if it causes low blood counts. And then we stretch that out to once every 3 months. The liver irritation is actually quite uncommon. When we see it, we either lower the dose or stop the medication and switch to something else. It's very, very, very unlikely that it actually leads to any problems long term. And even patients who do have fatty liver or steatohepatitis, so a little bit of irritation at their liver at baseline, will often start patients on these medications and just watch. And as long as everything stays stable, we'll leave them on the medication because we know long-term treatment is much more important than any small risk of side effect. And the other thing is we monitor, right? We're checking people, I'm checking blood work on a monthly basis initially and once every 3 months. So if there are a problem, we're going to catch it. In terms of lifestyle, this is some of the things that, everyone can do. And I think a lot of these would hold true for any chronic disease or, anyone who, I could certainly use a balanced diet and some more physical activity. So that's really important. I get a lot of questions in clinic about, is there, any special diet you'd recommend? The answer is generally no. I just say to eat a balanced diet. There's some interest in some Mediterranean diets. Nothing is really, well proven, but it's just important to make sure you're getting that balance. Physical activity, so 30 minutes where you're getting your heart rate above, up about 5 times a week. The Canadian government changed our alcohol policy recently. So, drinking in moderation, making sure you're addressing stress, right? Because stress is going to affect how you sleep, it affects your whole body. And then making sure you're getting a good night's sleep as much as you can. Preventative health is equally as important. So smoking cessation, because we know that people who smoke, not only are they at increased risk for rheumatoid arthritis, but our medications actually don't work as well when we're treating people with rheumatoid arthritis if they're smoking. So you might hear a rheumatologist harping on your smoking, and we can sort of redirect you to resources available. Vaccinations are important. So when we're suppressing your immune system, we want to make sure we give you the best chance if you do get a common infection. So the pneumonia vaccines are really important, shingles vaccines, and we'll often send a note to your family doctor around that. Rheumatoid arthritis is a risk factor for developing fragility fractures, so hip fractures when you're older or wrist fractures. We want to make sure we're on top of any osteoporosis that's present. As I said before, rheumatoid increases your risk of heart disease. So we want to do cardiovascular screenings. We want to make sure your blood pressure's good, your lipids are good. It'll really depend on who your rheumatologist is. A lot of the time we'll ask your family physician to do this because they're a little bit better at managing cholesterol than I am. But often we sometimes will do it too. And then just making sure you're up to date with your regular preventative health in terms of age appropriate cancer screening.
Thank you, Stephanie. That was a lot of information there. I'd love to ask you, what excites you about the future for people being diagnosed today with rheumatoid arthritis?
Yeah, so I'm actually really excited about how we deliver care, and the tools that we have to deliver care. Before, if a patient told me when I guess I haven't been I've been in practice for 4 years, but in residency, if someone said their joints were sore, but on exam, we didn't think there was anything present. That was kind of it. And if, they had positive blood tests for rheumatoid arthritis, we'd sort of say, well, we'll follow you over time and sort of see what happens. But now if I'm seeing someone who has a clinical history, so they've got joint pain that doesn't fit with my clinical exam, I'm really able to access imaging quite easily. So I'll send them for an ultrasound. We've got great access in all of the large cities across Canada. to look for any inflammation. And I definitely pick up stuff that I'm not expecting when I'm doing it. So I think the access to that is fabulous. And there's a lot of interest now in point of care ultrasound. So your rheumatologist might even do the ultrasound at the bedside, which is really cool because it's saving you a trip to go get that ultrasound. But it also means we're really aggressively treating that disease. And even if you've got some subclinical, so where I'm not feeling it on exam inflammation, we're going to see it and we're going to treat it. Um, the other big thing is that we're starting to see adoption of these multidisciplinary teams across Canada. So British Columbia just got funding codes probably, I think, about a year or two ago for nurses in rheumatology. So physicians can now have a nurse join them in clinic and be able to see patients because nursing has an awesome ability to provide some of the counseling and support that sometimes we're a little bit too time pressured to do. So I'm really excited about seeing that across Canada really become more standard of care. And then virtual medicine is sort of the other big area that's also changed how we deliver care, especially for patients who are remote. I actually I find the phone call sometimes a little bit challenging, but for patients are able to send me pictures of their joints, or when Emerge calls, they're able to call and ask for advice. They've put a picture of the patient's hands or knee or ankle or funny rash in the chart. I'm able to look at it right away and provide that sort of virtual phone advice that's quite educated, right? I've got that information I need, and if patients are having side effects or problems, that one is the biggest benefit of the pandemic is now I can talk to patients over the phone easily about what's going on, troubleshoot. I usually do a 6-week phone call after starting a new medication just to make sure everything's going great. And that's been a really big advancement, I think, for rheumatology and medicine in general.
Okay, so before we get into the Q&A for this evening, do you have any final thoughts or recommendations that you wanted to share with our audience?
I think the biggest thing I would say is that you really need to be your own advocate. And if you're worried about something, speak up and just let us know. If we know what you're worried about, we can address it. And I know I have young children, and I've taken them to appointments, and seeing a physician sort of ask me specifically, what are you worried about? And I went, oh, okay. And that really made a difference. And I think that's going to make a difference in terms of how you access care. Make sure those questions get answered, and you really need to feel confident and comfortable with what we're doing. So if there are questions, please ask them. We definitely want to hear them. So please feel empowered to do so.
Okay, that's amazing advice. So not surprising, we've received lots of questions this evening, so I'm just going to get going. We have received quite a few questions related to osteoarthritis versus rheumatoid arthritis. So maybe just to set the record straight on a few of these things. Can you have OA and RA at the same time? How do you tell the difference? Let's start there.
Yeah, definitely. So, we see osteoarthritis and it's going to increase as you're aging, but, and almost 40% of the Canadian population, depending on your age, is going to have osteoarthritis. And one of the risk factors for having osteoarthritis is actually having an underlying abnormality in the joint. So, whether that's you fractured your ankle or you've got rheumatoid arthritis. So we definitely see them overlap. And that's where sometimes it's challenging for me. And this is why I'm so excited about ultrasound is, patient will come in and they've got joint pain and stiffness. And I'm kind of going, well, I'm not really sure. Is it their underlying inflammatory arthritis or their osteoarthritis? And often we can get an ultrasound to help differentiate between the two, because the ultrasound, you'll see inflammation and swelling, but you won't if it's osteoarthritis, because our treatments are really going to change, right? And I could, prescribe a lot of disease modifying medications, really suppress that immune system, but that's not going to fix osteoarthritis. And it's going to increase your risk of other diseases. So when we're seeing people clinically, we're looking at the pattern of arthritis. Again, so for your thumb, the base of your thumb, that's always osteoarthritis. That's generally never rheumatoid arthritis. Or your joints at the tips of your fingers, that's always osteoarthritis. So we look at the pattern of joint that's involved and then our physical exam. And if we're not sure, we send you for an ultrasound.
So picking up on something that you just said, someone here is asking for a bit more information about how do you treat rheumatoid arthritis different from osteoarthritis? What does that look like?
Yeah, so rheumatoid arthritis, because it's this autoimmune disease where your immune system's working way up here, attacking itself, we've got to calm it down and bring it down. And we use medications like methotrexate, hydroxychloroquine, some of the biologics to bring that system down. And that's how we treat rheumatoid arthritis. Versus in osteoarthritis, we treat it more supportively. There's a lot of work going into can we get better treatments, but osteoarthritis, we're really using medications to treat pain and do joint protection rather than treating an underlying autoimmune disease.
Okay, I'm going to pick up on that as well. So we've had a few questions around medications and, really the difference between biologics, disease modifying agents, methotrexate, all of the ones that you just mentioned. So a little bit of confusion about what is the difference between all of these? For example, what's the difference between methotrexate and a biologic?
Yeah, definitely. So methotrexate, if you go home and or if you're on your computers now and you're Googling it, it's going to come up as a chemo drug. Um, and when we use it in rheumatoid arthritis, we're not using it in chemo dosing. So we're using it in a tiny fraction of the dose just to suppress the immune system. And it's given either as a tablet or it is often, especially here in Alberta, it's given as a subcutaneous injection, so in a needle once a week. The biologics are medications that are very targeted. So they've been developed in a lab in cells, they're proteins. So they take in a sort of very simplistically a petri disc. They're going to build this specific protein, and the protein is going to attack one of the inflammatory markers, like an interleukin-6 or TNF, and it's going to attack that or block that so that it can't cause inflammation. So methotrexate kind of acts very broadly. It's going to act everywhere. It's why some people will complain of some hair loss or some oral ulcers. It's going to attack any sort of quickly turning over cells, versus the biologics are very focused on what they're acting on. Because they're proteins, you actually can't eat them. If you ate them, your stomach would just break it down, and that's it. So we have to give them as an injection. So the biologics are usually an injection either once a week, once every 2 weeks, or once a month. It's going to depend on which one you're on, and there's a whole bunch of them now.
So you mentioned that you always have to try methotrexate first before you get to a biologic. Someone's asked, are biologics always better than methotrexate or hydroxychloroquine and other things?
Yeah, I was at the American College of Rheumatology meeting back in November, and that's the largest international meeting. And one of the rheumatologists during this huge session was sort of saying, well, you young people probably don't know how to use methotrexate or triple therapy. And the Canadians in the room were all like, what? So the biologics definitely have an advantage. They do work well, and I will say they're very well tolerated. You don't get the stomach upset that you see with methotrexate. You're not going to there's no risk really for hair. I have had a couple of patients, but it's very rare to get hair thinning, oral ulcers. So they are very well tolerated, but you do have to give them as an injection. The biggest reason we use methotrexate first is we're a publicly funded system in Canada. They're quite expensive. The price point difference is sort of probably $10,000 to $15,000, depending on which biologic. So we want to make sure we try stuff that is inexpensive and does work. Methotrexate works really well. And for someone most patients will tolerate it quite well. We just need to make sure that we're using our resources the best way.
Okay. So questions here about how do you know when it's time to try a different medication?
Yeah, so that's always something you want to have a conversation with your rheumatologist about. And when patients come in asking me that, I kind of take a step back and I say, or try and figure out why do we need to do, like, what are the concerns? Is it that you're not tolerating it? So you're getting stomach upset, or sometimes people feel kind of blah after taking methotrexate. Or is it you're getting hair thinning? Because nobody, men or women, do not tolerate that very well. Um, and sometimes, depending on if it's a side effect, we can actually address that. And we have some great options there. So if a drug is working really well, but you're having some side effects, we might try and troubleshoot the side effects. But if the drug's not working and you've got swelling in your joints, then usually we're escalating therapy. And that's often meaning we're adding another drug or we're switching to the biologics. And our tolerance 20, 30 years ago was that you shouldn't have it, that, a few swollen joints was okay and not to worry. But now we use this sort of treat to target approach. And that means we need to be as aggressive as we can with our medications to make sure you have no swollen joints on exam. And that's where our goal is remission, which means no swollen joints.
So if someone is being treated with whatever treatments for rheumatoid arthritis, a question here about whether someone should be expected to be on medications for life, or is there ever an option where they might be able to wean off of them?
Yeah, definitely. So we have patients who, when we have patients who have rheumatoid arthritis who are seropositive, and that means that your blood tests for rheumatoid arthritis are positive. And then we have patients who are seronegative, which means you've got rheumatoid, but your blood tests for rheumatoid arthritis are negative. And it's those patients who are seronegative, so their blood tests are negative, that tend to be more likely to go off medication. My general rule and most rheumatologists' general rule with them is you want to be in remission for at least a year. So stable on your medications, no swollen joints for at least a year. And then we look at either tapering medications or we try holding a medication. We do the same for patients who are seropositive, who are blood tests for rheumatoid arthritis are positive. We're a little bit more careful though. If your blood tests for rheumatoid arthritis are positive, you are less likely statistically to be able to go off therapy, but we definitely still try it. And one of our goals is always, how can we get you feeling the best you can with no disease activity with the least amount of medication? So we're always trying to pull back as we can. So there's definitely patients who go into long-term remission and we're able to pull off medications.
Okay. So earlier you did mention hormonal changes and menopause. So there's a question about whether, menopausal symptoms could in any way be confused with rheumatoid arthritis symptoms and kind of lead to a misdiagnosis or anything.
Yeah, definitely. Because, if you think about, you can get a lot more arthralgia. So that's sort of joint aches and pains around the time of menopause. Generally, if you're menopausal, you're in your 50s, you're also going to start to get some osteoarthritis contributing. So you might see your family physician and get a referral. When you see rheumatology, sometimes, as I said, we don't, we're a lot of what we're relying is on our clinical exam, and sometimes we're not always right with our clinical exam. So you might accidentally get told you have rheumatoid arthritis, but it's actually just related to your osteoarthritis. I'd say from what I see more commonly, it's that we miss the rheumatoid arthritis and sort of say, oh no, the pattern is a little bit more in keeping with osteoarthritis or just joint aches and pains related to menopause. But then over time, we follow people over time and we see how that evolves. And then we can often correct the course. And it is, again, it's sort of advocating for yourself if you feel like something's not fitting.
Okay. You talked about smoking being a risk factor for rheumatoid arthritis. Do we know anything about people who previously did smoke, in this case 20 years ago, and they've quit? Is it still the significant risk factor that you talked about?
That's a really great question. I'm not entirely sure, to be honest. Based on the other, like most of the other risk factors in terms of cardiovascular disease, cancer, that remote smoking history, the sort of further you've been out from when you smoked, is much less likely to cause problems. So we know that your risk for cardiovascular disease, for lung cancer, comes back to sort of the normal baseline risk once you've stopped smoking for a prolonged period of time. So an educated sort of conclusion would be probably the same for rheumatoid arthritis, but I actually haven't seen anything on that recently.
Okay. Can you talk for a second about how rheumatoid arthritis impacts people's eyes and inflammation in the eye?
Yeah, definitely. So as I said, rheumatoid arthritis can be a bit sneaky sometimes. And patients might end up seeing me not because they've had joint pain or swelling, but because they've gone in with a cough and shortness of breath, and the rest of the lung specialist has sent them to me. And the same thing for the eyes. You can get something called scleritis and other forms of inflammation of the eye with rheumatoid arthritis. It's not common, but we definitely do see it. The treatments are sometimes my job is quite easy. The treatment is exactly the same way we treat the joints. So we put patients on disease modifying drugs like methotrexate to quiet down that inflammation. I often take a lot of direction from the eye specialist about do they think it's active or not? And they kind of tell me yes or no. And then I may or may not escalate the treatment depending on what's needed. The other way rheumatoid can affect the eyes, and it's not directly, but it's related to our medication. So if you've had a lot of prednisone or steroid exposure, you're at much higher risk for cataracts and glaucoma. You're also going to be at risk for Plaquenil eye toxicity if you've taken Plaquenil or hydroxychloroquine. Now that risk is very, very, very small, and we screen for that. So everyone who's on hydroxychloroquine goes for an eye exam once a year. If we see changes concerning for any toxicity related to the medication, we stop it before you have a problem, before you notice any changes in your vision. But you can get eye involvement with rheumatoid due to the disease or even our medications.
And what about other major organs? You said that rheumatoid arthritis can affect other places as well.
Yeah, the common one I see, and I am at a sort of a larger hospital setting, is the lungs. So rheumatoid arthritis can cause something called interstitial lung disease, which is where the lungs kind of get a bit hard. So normally your lungs are nicely opening and closing, and then air gets exchanged across, you get oxygen flowing through. But in interstitial lung disease, the lungs get a bit harder, and the lining between the lung or the lining of the lung gets a bit harder to that tissue. So oxygen has a harder time traveling through. So it's why if someone, I'm always asking, it's why your rheumatologist is asking about your breathing. So I'm asking, do you have any shortness of breath? Do you have a cough? To make sure we screen for that. And then a lot of us will have close working relationships with respirologists so that if there is a problem, we can get on top of it, because we treat that also with the same medications or immunosuppression as we do the arthritis. It's really important to be on top of it.
Have you noticed any relationship between vaccinations, specifically COVID vaccinations here, and arthritis flares?
I've looked at this a lot. It's pretty biased data. They did have a registry in rheumatology during COVID looking at the vaccinations. The problem why I say it's biased because the physicians or patients self-report it. And if you have a problem, you're more likely to report the problem versus if you did well, why would I go online and sign up for this? The risk of flare is very, very low associated with COVID or other vaccinations. It's way under 5%. And the risk where you actually need to change medications is even lower. So we know that the benefits of our vaccinations far outweigh any risk in terms of the risk of flare of a vaccination.
Okay, this is a very tricky question, but I would love to hear your thoughts. We know that we have challenges with family physicians in Canada and access to GPs. So the question from a couple people actually is, what if somebody doesn't have a family physician? How would you recommend they seek out rheumatology care if they need it?
So my advice on family doctors is, and I will apologize. I do live in a large city, so I don't have a great I haven't had to live in a place where there's not access. But I would say usually wherever you are, there's a website or there's a phone number, and register, or at least get your name on a wait list. So we're here in Calgary. You can look. There's physicians accepting it. Just pick anyone. It doesn't have to be your idea of the perfect family doctor. And then, you can shop around, you can talk to friends. I always tell friends, if you hear of anyone, let me know who's accepting. But there are definitely walk-in clinics across, that you'll have access to. And a walk-in clinic could definitely do a referral. We will accept referrals from anyone, whether that be an emergency physician, a walk-in clinic physician. I get referrals from nurse practitioners also. So you just need a referral through primary care, whether that be your own family physician you've had a long-term relationship with, which is not common in Canada anymore, or it's someone you've walked in to meet. And just want to, tell them what your concerns are and then ask for a referral. And usually we get a lot of referrals that way. Once patients see me, I tend to then sort out, a lot of the primary care issues. Then, I might try and fill a gap where I can and see what I can do to get patients connected to a family physician.
Okay, I think I have time for one more question here. Someone is asking, why is it not called rheumatoid disease versus rheumatoid arthritis, with a little bit more context about how they think it's a really serious disease and people don't take it seriously when they hear that. So I just wonder if you experience that in your practice, in your communities, about people taking arthritis maybe not seriously enough.
Yeah, it's really frustrating. People know what heart disease is. They know what, breast cancer is. You know what having a stroke is. And those are also really serious. But rheumatoid arthritis can have such a profound impact on someone's ability to function in day to day. And I've had patients come in whose hands are just floridly swollen. They can't make a fist. They can't do anything. And they're trying to go to work, or they're trying to take care of their young children. And there's not a lot of understanding in the broader community about it. And it's sort of, well, you just have arthritis. So we do a lot of work in terms of supporting our patients around how we can get them the right accommodations, how we can do education, sort of with their employer, with the schools. We do see juvenile idiopathic arthritis. How can the school better support? How can your employer support you? Because we know staying in the workplace is so important. So getting that support and having that understanding is really important, and just getting the message out as much as possible. Letting your family members know how you're doing, how you're feeling, and what the problems are, because it can be a bit of an invisible disease because people just don't understand.
Yeah, so Stephanie, I would say we at Arthritis Society Canada agree with you 100% and would echo everything that you just said. So thank you. Thank you for sharing that, and also all of your expertise with us tonight. We'd like to take just a few moments to get the audience's feedback on today's presentation. So for those of you watching on Zoom, you should see a poll question pop up on your screen with some answer options. So obviously click on the response that reflects your thoughts. I feel more knowledgeable and empowered after attending this webinar. We will also be sending you an evaluation form when we set up the recording of the slides. So if you weren't able to access that poll question, you'll have the opportunity to give us feedback at that time. And we really do carefully review the survey feedback, and it helps us shape our future Arthritis Talks webinars. So we value your input. So thank you so much in advance. People are also waiting too long for joint replacement surgeries, and we need your help asking governments to take action. So if you'd like to help us, please go to arthritis.ca/wait times to add your voice. Once again, we are grateful to Pfizer, United Way Winnipeg, and others for their financial support of this event. With that, this concludes tonight's Arthritis Talks. On behalf of all of us, thank you for joining us today, and please stay well.